Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. So in this another interesting vlog, I'll be presenting a very interesting sign. I call it spring back sign, and this is a typical case of a cortical soft cataract. You can see that it's a grade 1 cataract, and this is a kind of cataract where we may land up with the bowl formation. I have explained in previous many videos how to avoid that situation and how to come out of this situation as well. So we'll be having some repetition of few things here. So 2.8 inch is what I prefer, and I always use the combination of hyaluronate and chondroitin 3% and 4%, and that works great for my cases. This is a Inamura's forceps, little bit modified. You can see little bit curved tip there, a gift by my Italian colleague, and there are these markings as well on the forceps which will help me in gauging the size of the capsulorhexis there. And in this case I'll be placing a toric trifocal IOL, so naturally I'm not going to have very big capsulorhexis here because I want it to be covering the optic 360 degree. So if you have a big eccentric rhexis, then it's not possible later to modify that capsulorhexis. But if you have a smaller capsulorhexis, like this appears to be around 4.5 millimeter to me at this point, and it's well centered around that Purkinje image, as you can see. And hydrodissection, I think you must have seen my previous video. If not, you just go back and see the right point of pushing that fluid, and way you feel the resistance while you are pushing the fluid. That is the key or the secret behind successful hydrodissection, and that's what basically the experienced surgeons pick up. So it looks as if it is very easy in experienced hands. The reason is that it's not just the visual cues that the experienced surgeon is picking, it's also the resistance that the surgeon's hand is experiencing. That's what makes hydrodissection very reproducible. So let's move on. I have removed the anti-epinucleus there, and narrow and long trench. It is not necessary to have very long trench, but long enough, and you can see the first split is complete. Again I am going for the second split. Now here, if you have noticed, it was not adequate depth of the trench and the division was achieved, but I am not very satisfied. Again, very shallow trench, and though I could divide it, I know that it's not complete division, and this is very common with these cataracts because you kind of avoid going too deep, and also the central part sometimes divides, but peripherally you can see these pieces are still attached. The first aim is to have at least one piece which is completely free. Now here I want to show the spring back sign. It's a big piece, and you can see the moment I am trying to pull it out of the capsulorhexis, it's going back. So watch it again. I am trying to pull it out, but it just chips little part of the piece and it again goes back. Again I try to pick it out, but again you will find there is a springy action which pulls that piece of the nucleus back into the bag, and that is basically the zonules which are being stretched. So the zonules provide that spring action, and it's because this piece is not completely free and this piece is bigger for that capsulorhexis. So I need to make space. So I go to next piece which is completely free from both sides. Now space is made, and now I can pick up the first piece quite easily without pulling the bag like I have shown in the spring back sign. Whenever there is a spring back sign, just realize that you are pulling the zonules basically. So always make sure that piece is completely free. If that piece is too big, either you try to divide that piece or you take out another piece. So make some space and then take out that piece. So again here the piece is still attached, so I divide that piece and then I will pull out and emulsify the remaining part of the nucleus. So watch that video spring back again, because this is a very common thing to happen in beginner's hand, where they don't realize, they keep on pulling that piece and failing to pull it out of the bag completely, and in that attempts there might be a zonular weakness which is developing. So always watch for that spring back sign. Another thing which you have to consider is the posterior capsule. So if you have noticed, if you go back and see, I changed my illumination to only retro illumination when I started quadrant removal, because I was watching the posterior capsule. Because in certain cases, like in this case, you will find soon that the posterior capsule is more redundant, and particularly when you are picking out the last pieces of the nucleus, it might come little anteriorly. So always keep watch on the posterior capsule. Once you have divided the nucleus into pieces, then you just need to do the quadrant removal while watching the posterior capsule. Now you can see here that the posterior capsule is kind of bulging little bit and making the incisional cortex removal little bit difficult. Here I have to be very careful that the tip of the eye is carefully directed only towards the cortex, because it might catch hold of that bulging PC or the redundant PC anytime. You can see some fluid accumulation behind the posterior capsule as well. This is seen but not noticed in many cases. At the end of it, I am using the or inserting the IOL. I always use 1% hyaluronate to form the bag before I implant the IOL, because it's easier to wash it off. So the IOL goes in the bag, I align it properly, and you can just keep the IOL in such a way that it's easier to rotate this IOL clockwise, so you can keep it on the anti-clockwise side little bit, so that when you are washing the visco it still remains at that point, and then you can rotate it to the final axis. Always very important to wash out all the OVD from the bag. So you go behind the IOL and wash it off. The advantage of 1% hyaluronate here is that you don't have to go and clean from the equator of the bag, because it comes out in one bolus. So it's much easier, particularly for all IOLs of course I use, but for toric I definitely recommend, because you don't want any visco which may lead to further rotation of the IOL later. The optic is nicely covered 360 degree. As I mentioned, it's slightly on the smaller side, maybe around 4.5 millimeter, but I am not worried in this particular case, because there is no risk for developing anterior capsular phimosis in this patient, and the material is hydrophobic, and usually in these particular type of IOLs I have not seen much of anterior capsular phimosis, so I can leave it alone. But of course, if you want to be more perfect, you can create a nick and enlarge the CCC size to say 5 to 5.5, but this is fair enough, and I have seen the cases do quite well in post-operative period. Also Indians have much smaller pupil, so that's not a bothersome for us. Do watch and subscribe to my YouTube channel. You can write your comments as well on various videos that I have uploaded. You can go through the playlist. There are specific playlists for different things, like even practice management, different types of cataract, soft cataract, hard cataract. There is a thought process, phaco training, experience of different surgeons. Thank you so much for watching.